Thank you, Dr. Kermani. It's a pleasure to participate in this great session, along with many friends, on the debate about keratoconus pathophysiology, diagnosis, and management. So my topic is advances in diagnosis for corneal ectasia, and these are my financial disclosures. I'd like to start with some wisdom from Bida. The three paths for failure is not to teach what you know, not to practice what is taught, and not to ask what is ignored. So considering that, we need to understand advanced diagnostics for corneal ectasia. When we screen patients for ectasia risk prior to laser vision correction, we go beyond but not over the detection of keratoconus into the domain of characterizing ectasia susceptibility with enhanced screening tests. When we manage patients with corneal ectasia prior to keratoplasty, considering a paradigm shift, we need to understand what the patient has, the severity, using objective and subjective data, which is going to be the diagnostics for corneal ectatic diseases for personalized medicine as a different path than when we characterize ectasia susceptibility prior to refractive laser vision correction. This is truly an evolution that is a revolution in evolution. Multimodal corneal imaging, we have the what's and the whys, what we're trying to achieve in terms of what is the goal of your work in terms of screening, early diagnosis, prognosis, classifying ectasia, staging the disease, more detailed follow-up, which is important for patient orientation and education, and treatment guidance for refraction, contact lens fitting, customized surgical planning, and of course for the detailed follow-up. And we have multimodal imaging, and we have multimodal imaging in the algorithm with applied artificial intelligence and ancient intelligence, the philosophy, so that we understand the whys, so that we can take the advantage of these technologies for making the best decisions for our patients. We know that corneal topography enable us to detect ectasia, keratoconus, subclinical prior to the development of slit lamp signs and loss of distance correct vision. Interestingly, ectasia is defined as a thinning disease, and the pattern, the thinning location, will be important for us to distinguish between a true pellucid, a keratoglobus, and an inferior keratoconus or a more global keratoconus. For example, the false pellucid here with the kissing birds with a vertical flattening against the rule of astigmatism with inferior steepening in this lazy C pattern is different when you have the thinning pattern of a false pellucid than when we have a true pellucid with this severe inferior band, which is pellucid, which is transparent, which is not opaque. There is no lipid degeneration, no vascular infiltration on the cornea, and you have this thinning pattern, which is important for us to identify true pellucid. When we think about diagnostics, we go for multimodal imaging, and we have many machines in the market. The Pentacam today has axial length and ocular wavefront, and this is going to be important for us to detect other situations, not only ectasia like angle closure glaucoma. And this data will help us to making clinical decisions in terms of lens surgery, for example. When you think about keratoconus and ectasia diagnosis and screening, we have the Bell and Ambrosio with the enhanced elevation front and back surfaces and thickness profile. The D's are the deviation from normality, and the big D, the final D, is a linear regression analysis for optimizing the understanding of ectasia, even in subclinical cases. Interestingly, Michael Bellin also has developed the progression display, looking at the repeatability of the parameters, the radius of curvature at the thinnest point in the front surface and the back surface, and also the thinnest point. And you can see if this patient has a progression that is statistically significant considering the repeatability of the measurements within a keratoconic and a normal population, which is what we consider for the very mild cases. The number of publications and the interest on keratoconus have increased tremendously over the last decades, especially when we started with refractive surgery. We know that keratoconus is not a new disease. It has been very well documented even before, but we have the seminal work by John Nottingham that is probably the first good publication about keratoconus, and the role of refractive surgery for the diagnosis and treatment makes like a paradoxical influence, like is an ally or an enemy. Why? Because we have iatrogenic keratoectasia. The first description of ectasia, for example, after LASIK, came relatively late in 1998. And the first cases are cases with high myopia treated by LASIK, in which the impact from the LASIK procedure caused iatrogenic ectasia. A few months later, still in 1998, iatrogenic keratoectasia in a form fruste keratoconus defined from the front surface topography will be alluded to the progressive ectasia, considering the abnormal biomechanical structure of such cases. Those two reports, they allude perfectly to the pathophysiology of ectasia, in which I would say is probably related to any disease in medicine, which is related to the innate properties of the patient and the environment. Considering ectasia, corneal properties are related to biomechanics, and the biomechanical decompensation cycle, nicely described by Cynthia Roberts and B.J. Dupes, will be related to the innate properties of the cornea and the impact from the environment, including laser vision correction procedures. But the more important is the eye rubbing, which is continuously done by the patient, that causes the cornea to undergo ectasia, progression, and eventually the developing of the disease. A major point is that any cornea may develop ectasia, so that we tell people not to rub the eye. And it's a major message in our Violet June Keratoconus Awareness campaign that I invite all of you to participate next year, to tell people not to rub the eye. And eventually I invite you to understand that eye rubbing aggravates keratoconus and may even cause ectasia. Ectasia risk score system by Brad Rundle is a major contribution, in which you look at the topography pattern as a surrogate of the corneal structure, along with age, which is a very good surrogate of corneal biomechanics, along with the impact from the procedure. And my humble consideration here is that forme fruste keratoconus should not be a topographic pattern. Of course, irregular topographies are important, and the surgeon should know how to read topographic maps, but we need to go definitely beyond and not over the front surface of the cornea, and beyond but not over the understanding on what is forme fruste keratoconus. So what is forme fruste keratoconus? It was described by Mark Emsler many decades before topography was available. Interestingly, there are forme fruste diseases not related to ophthalmology, as described by the forme fruste psychosis by Sigmund Freud. Interestingly, Yaron Rabinovitz would say that the forme fruste keratoconus is the irregular topography eye from a patient that has normal slit lamp and normal distance correct vision. The fellow eye of this patient will be based on the editorial by Steve Kleiss in 2009, considered forme fruste keratoconus. We have learned tremendously from those very asymmetric ectasia cases over the last years. And it's important to understand that topographic criterion is not going to be enough for you to separate forme fruste from normals, considering this very nice scheme by Damian Gatinel. It's very important that you have, based on objective data, a normal and keratoconus separation, but the subclinical cases will fall in between. And we definitely need to go beyond, but not over, corneal topography. A nice systematic review of the literature found huge variability on the definition, the criteria for these studies, considering subclinical and forme fruste keratoconus. In fact, there is no consensus, and my humble contribution is that forme fruste keratoconus is not a topographic pattern, but should be defined as cases with high susceptibility for ectasia progression. In 2008, we took this paper at the AAO for the first time with this concept, and we are also debating about elevation versus curvature. Interestingly, this case was presented by Doug Koch, and I was able to get the data, the U12 files from the Pentacam, and do a detailed analysis. And a lot of people would say that this will be pathognomonic for forme fruste keratoconus. I was really frustrated, and this consideration led me to the study on the variability of subjective classifications of corneal topography done by experts. So this is case number 6, in which we found a huge variability from 0 to 3 with a mode of 0, with the first scale, the 1.5 diopter Steve Kleist scale, and with another scale, the half a diopter normative scale, we found also mode of 0, but varying from 0 to 4. Interestingly, this case was found with ectasia susceptibility because of the D that was higher than 1.4 and the artmax that was lower than 400. Interestingly, we have other cases published with the same scenario, like the SMILE case that developed ectasia, the first publication of ectasia after SMILE that has a biomechanical advantage, but you still cannot weaken a cornea that is abnormal. And we got the U12 files, and from the front surface, we were able to detect what we consider to be a low K keratoconus with many of the parameters that is abnormal. And I would say this type of table is very important for you to see the cutoff and the sensitivity and specificity for each of these parameters to develop the diagnosis of ectasia. So this case came handy as an example from the CareNet. The colleague took the picture from his smartphone, but we need to go beyond in the analysis. Interestingly, from the front surface, you have the differences in the aspect of topography if you change the scale. 1.5 diopter Steve Kleist scale. This is half of diopter, the classic ICs, which in the Pentacam is called the holiday scale. We have 0.25, which makes this prolateness of the cornea more pronounced. Interestingly, we have the Ambrosio 2 scale, which is an absolute scale, and also the absolute scale with a half a diopter with a palette from the Atlas Humphreys Eyes topography. The topometric maps lead us to topometric objective data, and this case has an abnormal TKC. Interestingly, the tomography, the thickness profile is abnormal in both eyes. You have also some abnormality in the quad map on the back surface elevation, and the BAD is abnormal, as it is the PRFI, which is an advanced function. However, this case will be considered as a bilateral form Fruste keratoconus, and we find those cases in some of the patients from the families members of keratoconus and other situations. But this is important that you go to understand what these cases are. It's not a keratoconus, but a susceptible. Another quote that I come to my mind is that we have to evolve always. And understanding that we need to evolve is that the D in a larger population with 105 ectasia cases in which we had the pre-op Pentacam, we got the sensitivity of 60%. Random forest analysis of the tomography data would lead us with a higher ROC with more sensitivity, but still with about 25% of these cases. Some of these cases are related to the impact from surgery, but it's clear that we have to go beyond, and we go beyond the analysis in corneal shape, considering segmental tomography with high-frequency ultrasound and OCT. The segmental or microlayer tomography allow us to see layers like the epithelium, the flap, the endothelium, the Bauman's layer, and this is pioneered by Dan Reinstein, in which he can identify thinning patterns in the contrast to thickening patterns when you have inferior steepening. There is a very nice algorithm that is done by machine learning using the Artemis, the ARC scan, which is high frequency ultrasound, and we also have this type of data on the OCT with a pattern standard deviation that can separate a keratoconic cornea from a case of warpage. So based on the thickening here is related to warpage instead of a thinning here that is related to the mild keratoconus case. We have this summarized in this review paper in the Current Opinion of Ophthalmology in 2017, in which the role of corneal epithelium for the refractive surgeon is very nicely reviewed by Marcela Salomon. But going beyond the characterization of corneal shape, we have the characterization of biological properties, including wound healing and biomechanics. And I have a quote from Roberto Oliveira, colleague from Brazil, that this is an example from the past that never existed. But today we can do that with the Corvis. The Corvis takes in 31 milliseconds 140 images with a Scheimpflug camera. And this can separate a normal cornea from a weaker cornea based on the CBI, which is going to take into the consideration the deformation response and shape, the velocity, and all this data can separate if the cornea is softer or stiffer. Interestingly, we can have a PRK case presenting with the steepening on the front surface, and this patient was sent to me for considering a cross-linking procedure, and it is not ectasia after PRK. This patient has, in fact, haze, which should be managed completely different than a corneal ectasia case. Our idea is to combine tomography and biomechanics, and we have done that with the random forest approach as well, which is artificial intelligence and help us to separate from a normal population one eye randomly select for the clinical ectasia cases. 204 keratoconus cases, also one eye randomly selected, and we have 94 cases with normal topography based on strict criteria, and the 72 unoperated eyes that are fellow eyes of these patients. Some of these cases had the fellow eye done cross-linking, rings, or transplants. So this is a surrogate or an epitome for the biomechanical susceptibility. So we have an example here of a patient that has a normal topography and relatively normal D, that the TBI is abnormal and the fellow eye has a mild keratoconus. And this will be a high susceptibility for this eye to develop ectasia. Interestingly, when we have cases with both eyes, like the three daughters of a patient that presented with keratoconus in Shizuoka Ko from Japan, the three daughters with normal slit lamp, normal distance correct vision in both eyes, all the three daughters have some abnormalities found in the tomography and biomechanics. Interestingly, the bilateral form Fruste came in a very nice report from a bilateral twin sister with both eyes normal. The twin sister, the first sister, has a very symmetric ectasia, and you see the TBI is abnormal in all the four eyes. Interestingly, this patient was analyzed by the EVA gene testing that found some of the genes that may be markers for keratoconus susceptibility. Ectasia can occur in only one eye. This patient was followed by Dan Ringstein after having corneal ring at my clinic. The left eye was very normal, and everything was still normal on the epithelial thickness and the Damian-Gattinel orb scan score, and this eye was considered as a unilateral ectasia, also based on the 2014 retrospective TBI that was still normal a few years later. So interestingly, we have the wisdom that true unilateral keratoconus does not exist, and keratoconus, while being bilateral, secondary ectasia can be unilateral due to the mechanical process. Interestingly, it can be even in both eyes, and then have to be keen to understand ectasia susceptibility and how the impact from surgery, considering surface ablation, femto LASIK, LASIK with keratome eventually, and SMILE or even fake IOLs, or if the patient has a disease and needs to have a therapeutic approach. Another wisdom that sometimes we know enough to think we are right, but not enough to know we are wrong. And with that, I come with the cases that were published, the studies that the sensitivity of the TBI will be much lower sometimes than what we previously published. And we know artificial intelligence is still in evolution, and with the optimized TBI, with a larger population, we were able to optimize in this multi-center study based on 25 centers that increased from less than 100 to over 500, so more than 5 times the number of cases that we have with normal topography from patients with very symmetric ectasia. And we were able to improve the sensitivity about 10%, keeping or even improving the specificity. Interestingly, I have a case report here, just to finalize this talk, with a patient that presented with very asymmetric ectasia. How the exams can help us. Exams can help us first confirm ectasia in the right eye. This is a patient that has mild keratoconus in the right eye despite of 2015 corrected distance vision, and also in the left eye, not only because he was 13 years old, but because of very low SPA1, which is the stiffness parameter at the first applanation moment. This patient has a high susceptibility for progression. He decided not to do surgery, even though I told him he should do surgery right away, which is something that I don't do for all cases. But you see the progression occur here. When we look at the Kmax, you may be misleading, but at subtraction maps, there is a clear steepening in the zone, which is obviously very nicely detected by the ABCD. A final major advance is the Hamburg Best Display, which is a biomechanical evaluation that correlates to tomography, that you can see the progression of ectasia and even the regression after cross-linking. This is a must when we consider multimodal imaging, artificial intelligence applied with the hows and with the whys. So that is artificial intelligence and ancient intelligence applied for a customized evaluation for biomechanical susceptibility and all the keratoconic diagnostic screening, staging, prognosing, classifying, and detection of progression. So this is a true revolution in evolution. And I thank you very much for your kind attention. And I really look forward to the nice discussion that we'll have. Thank you.